Even with these stage D, these end-stage heart failure patients, 85% of them, will get better on medication. So of the patients who get referred to us, they're all referred by other cardiologists. They're all told that they're end stage. Yet 85% of them will do better on medicines. 15% of them will evaluate for what we call advanced surgical therapies. And that could be transplantation. That could be a ventricular assist device, which I describe as a partial artificial heart, helps one side of the heart. It could be palliative care. So sometimes we can't cure what it is that presents to us, and so as opposed to focusing on cure, we focus on palliative care, which is not the same as hospice, but it's learning to live with a chronic disease.
Time to embrace change and be about that life. This is Dr. Vass with the About That Life podcast, the podcast about life or living intentionally forever. As you all know, February is Heart Health Month. It's a month where we dedicate our minds, our heart to the prevention, to the treatment and the management of heart disease. Well, as you know, I'm a cardiologist, but there are a host of different cardiologists set to treat, manage, and care for every type of cardiac patient there is. Understand, I simplify heart care into three ways, right? You can have a structural problem with your heart, you can have an electrical problem with your heart, or you can have a plumbing problem, right? And there are different cardiologists to address that. Well, today I'm talking with one of my mentors, probably one of the most brilliant people that I've ever had the ability to come in contact with, and looking at his curriculum vitae or CV, that's a resume for physicians, they didn't spare an expense on trees. I'm glad he sent it digitally. He is one of this nation's leaders in care for heart failure. So today we're going to talk about heart failure, but understand how it's changed over time, understand how therapies are evolving. I want to introduce to some and present to others my friend, my mentor, and my colleague, Dr. Michael Kwan. How are you doing today, sir?
Hey, great, Travis. Thanks for the intro.
No problem. Well, it was easy. I looked at the CV and 25 years of heart failure. And I know just in the past 5 years, it has changed so much. So in that, I guess I have to say, why heart failure? What made you select heart failure back in 94, 98, that time? What made you pick heart failure?
There's two stories. One is I kind of defaulted to it because at the time I wanted to stay in San Antonio, and my wife at the time couldn't leave. And so I had to find a job that I could do here that wasn't done elsewhere. And heart failure is kind of where we defaulted. That's how I ended up doing it when I was still over at BAMC. Mm-hmm. When I left the military, I was trying to decide if I wanted to do general cardiology or if I wanted to do heart failure. And I'd actually decided on general cardiology. Then what happened was the way I got deployed, I got sent to Iraq as a battalion surgeon, not to a field hospital. So there I got a chance to just really work with a handful of people, and I knew them and their stories really well. I knew their families and the stories behind the story really well. And I realized for me that was much about what I liked about heart failure and transplant. You got to know a handful of people really well. You got to know their entire support structure really well. And so for me, I actually kind of changed my perspective. So when I came back, as opposed to doing a general cardiology job, I said, this is what I like to do. I like to be highly engaged with a handful of people, but know their entire story, not just treat one part of the story.
Wow.
So when I got back, I actually kind of changed tracks completely, interviewed for a new set of jobs. A lot of the people that already accepted me for a general cardiology job were very understanding of that. And I still work with them as colleagues now. So wow, it all worked out.
And it's interesting looking back at kind of John Hopkins, behavioral science, thing going on, and then having this shift, because oftentimes what I tell people is where you start is often not where you end up. And your story kind of resonates with that. You mentioned something that I heard that when I looked at your CV that I saw, it's this concept of service, concept of connectivity, concept of communication. Mm-hmm. Now, how important is communication, not only in heart failure, but just in caring for people in general?
I think if you care, you listen, right? Mm-hmm. And I think that learning how to communicate is important because, as a physician, you're always an educator, right? It's not just treating the problems, but it's educating them about what to look for. It's educating the family what to look for as well. Mm-hmm. So I think that's huge. And being able to kind of not only communicate, but also to be able to listen. Because oftentimes patients don't necessarily know what symptoms relate to the heart, what symptoms don't. And you have to be able to let them talk and let them kind of put that out there. I think that's one of the things I like about our specialty. We're not set to 10-minute visits.
See, that right. My question, because I say I don't know how you educate in 10 and 15 minutes after getting vitals and weights. And how do you do that? But you just said, we're not like other specialties. We allow ourselves the ability to, and I don't want to put words in your mouth, but talk about that. Talk about how heart failure is different. And we'll define heart failure and all that a little later, but talk about how this is a different practice, because there may be physicians who have an interest in going into heart failure exclusively. How is it different?
So I think what we like about it is that it is, again, it's people that you get to know well. But so you know them over a series of visit points, not just at one point in time. And I think that one of the things that we really try to emphasize is the educational piece. But you can't do that in one setting, right? It has to be reemphasized from visit to visit. Yeah, I talk to my hands too.
No, that means when people talk with their hands, this is what I heard. It's that they're open.
So I think that, what we try to do is we try to reemphasize, because one of the mantras is that people hear about a third of what you tell them. So you have to kind of repeat it 3 times. And so, having a series of visits, when they're in the hospital, when they're in the clinic, when they're with their family, I think that's really what we try to focus on, because the patient education piece is huge. Because if they know when to call before they get into where they get, when they call before they get sick enough where they have to be hospitalized, ounce of prevention is really worth the pound of cure. Right. So we emphasize that at multiple levels, because as you probably know, patients will tell a nurse what they won't tell a doctor, what they're afraid to ask a doctor. So that happens on all levels. Even our medical assistants, when they're taking the vitals and doing the EKG, they'll ask how the patient is doing, and they can reemphasize some of those same messages. So from the top all the way down, from the doctor to the nurse, through the medical assistant, we all try to focus on trying to teach them what to look for, what are the early warning signs, when to call early, and then being available to field that call. Our clinic is deliberately set up so we have buffers, we have flex time so that we can bring patients in as a walk-in if they get sick enough to try to avoid an ER visit. So again, highly engaged with a handful of patients, and that's one of the things that I find really attractive about the field.
Well, I need to join the team. That sounds like fun, because it looks like you all are creating an environment where access is prioritized, where value is driven into every visit. Like you said, from the front desk when they check in, to nursing education, to the data that they're moving with physicians. And I really think it's a model that folks hope to aspire to. But I could tell you, in our current environment, unfortunately, that's not always the case. Now, you mentioned warning signs. Now, when we talk about heart failure, what is heart? How would you describe it as an expert? How would you describe heart failure?
So I think heart failure is a wastebasket diagnosis, much like cancer is a wastebasket diagnosis. There's 1,000 different forms of heart failure and 1,000 different prognoses. So it's really important to kind of clarify why somebody has heart failure and how it's going to be treated and what the implications are long term. Because if you look things up on the internet, you'll see really scary stuff about 50% 1-year mortality. That's true in some, but not true in all. So I think in general, we think a heart failure is just a weak heart muscle for whatever cause. And again, I think the key is finding out the causes and treating the cause as well as treating the symptoms. So it's not sufficient to say, okay, if you're retaining fluid, let's just remove the extra fluid with diuretics, water pills. But why are you retaining the fluid? What is causing the heart failure? And that's why I think having the specialist kind of look into that, not just your general practitioner, but your cardiologist really kind of do a deep dive into what's going on. Then we can treat not only the symptoms, but the causes of those symptoms as well.
And I think that's helpful for patients to understand that, heart failure is not a death sentence. It's not a, hey, this is it. I've got heart failure. Because I had a patient, and again, you touched on it, 2 separate, I like to make it simple, 2 broad categories. One where the heart squeeze is okay. The other one where the squeeze isn't as good. But either way, it's still, the heart's not giving you enough blood or nutrients to do the things that you want it to do. And so this was a heart failure patient with a preserved squeeze function or ejection fraction who was told, you've got heart failure. And all they read, just like you, they went online and they saw the 50, they came in and said, well, I might as well stop taking my medicines. I said, no, that's the wrong answer. But it was that re-education from what they heard about that. So heart failure has various stages and classes, not to get too sciencey, but I usually do tell my patients, hey, this is where you are. Can you speak to the stages and classes, and then we'll touch on where you pick these patients up at that latter stage?
Sure. So I guess without getting too medicine-y, so the stages are the worst that you've ever been, and the classes are where you're at currently. So somebody who is stage A, they have risk factors for heart failure. Stage B, they have structural disease, but may have never developed symptoms. Stage C, at some point in time, they had symptoms. And stage D is technically defined as end stage. So if somebody was on a mechanical device to help the heart beat better, if they're on IV medicines because they're that sick, then they're technically stage D. However, the functional class is where they're at right now. So functional class 1, they're up there doing everything they want to do, to functional class 4, where they're short of breath, just sitting still. So somebody comes into the hospital, well, if they've had symptoms, they're stage C. And if, depending on how sick they feel, they may be a functional class 4. But when they leave the hospital, they may feel great. They're doing laps around the hospital. They're now a class 1, but they're still stage C because they had symptoms. And the reason we use those stages is just like stages in cancer. It gives the provider an idea of how sick is this person really. Were they ever symptomatic? Were they ever being considered for a transplant and got better? Because when they walk through the door, they look great. But for us, it's important to know how sick were they at their worst so we can be appropriately aggressive. So the stages are, where they've been, and the functional classes are where they're at now.
I love it. And you even simplified it more than me. That's what I'm going to take that soundbite and use it to help folks understand that, hey, look, even though you're stage C and you read on the internet, you're class 1, you're doing great. You're walking, you're looking, you're giving me my 12,000 steps a day, and you're hitting all those targets. But now let's shift gears and talk about that group of patients that you care for, the vast majority, because, and first off, thank you for caring for some of my sickest patients. I still see them on the cardiology side, but you really manage their care, and most of them come back brighter, more optimistic, educated about their disease. Let's talk about that kind of stage D group that is toggling between class 3, class 4. I'm optimistic class 3, but in many cases they're class 4s. Let's talk about those for a minute.
So, I wanted to point out that you're still C. And so that's the key. Even with these stage D, these end-stage heart failure patients, 85% of them, will get better on medication. So the patients who get referred to us, they're all referred by other cardiologists. They're all told that they're end stage. Yet 85% of them will do better on medicines. 15% of them will evaluate for what we call advanced surgical therapies. And that could be transplantation. That could be a ventricular assisted device, which I describe as a partial artificial heart, helps one side of the heart. It could be palliative care. So sometimes we can't cure what it is that presents to us, and so as opposed to focusing on cure, we focus on palliative care, which is not the same as hospice, but it's learning to live with a chronic disease. So diabetes, rheumatoid arthritis, those are in heart failure. They're all appropriate for palliative care, not just cancer, not just end-stage heart failure, but trying to get the maximum quality out of your life as well. And I think it's important to have that balance. We actually look at the guidelines for people who are stage D heart failure and are refractory stage D. The decision points are consider them for a transplant or consider them for palliative care. There's not a whole lot in between. But at the same time, there is a lot of quality of life that can be had on the medications as well. And all the patients, like I said, that get referred to us are told there's nothing more that can be done. Yet 85% of them, years later, are doing well on medicines.
And I can say that's been the case for many of my patients, right? Because I will diagnose them with amyloid, and they're out of that magical, if you could say, that window where I could give them a medicine, and I send them here, and we have the discussion, and I bring the family in and talk to them. And one of their questions is, well, will you still be my cardiologist? I said, sure, I'm still going to be a general cardiologist, and I'll still work on the other things, but Dr. Kwan will garnish that care that you need to put you on that pathway potentially for transplant. And I know that's something that you've been doing, looking that you're on the board. You've kind of really grown. We're in a new facility, new for me, because I remember when I came and you'd walk in, the waiting room was it was nice, it was cozy, but we had 4 rooms and this office, and we shared an office, and now we have this beautiful facility. And that tells me, number one, you're doing a wonderful job, and I could see it for myself with my patients. Number two, the issues and problems of heart failure are only growing. So when you get that patient that is kind of at that end and you're having to make a decision, talk about transplant, because I know that's a scary point, and we've shared a patient that's both near and dear to both our hearts that did everything right, got there, but the outcome wasn't necessarily what we wanted per se. But talk about transplant.
No, that's great. I think transplant is oftentimes seen as a cure, and it is a great therapy, but it's not therapy for everybody. To kind of put things in perspective, we consider high-risk cardiac surgery something that has a 3% mortality risk at 1 year, whereas transplant has a 9% risk at 1 year. So it's 3 times higher than what we would consider traditionally high risk. But these are patients who are really at the end of their rope. So oftentimes they've been through a surgery, they've been through multiple doctors. So evaluating them for transplantation, if they're a good candidate, it can really lead to improved survival, improved quality of life. But it's also a trade-off. I tell people it's not like a gallbladder surgery. It's not a one then done. You're not fixed. You've exchanged one set of problems for another. But on the medications, you can have an excellent quality of life. One of the things we wanted to do in this clinic, we want to have a wall full of pictures of, the transplant patients, the coolest things they've done. So we've had people who have gone scuba diving, skydiving. We had one that went to Antarctica post-transplant. And it really does restore that quality of life. So they can go back living a full and meaningful life. But there is a huge workup process, and it involves not just the patient themselves, but their entire family. Because we tell everybody it's a family sport. You need to help your family. You need the support of your spouse. And I think that the evaluation process isn't just focused on medical, it's focused again on the entire support structure and whether or not the patient and their family can do that. Because once you get a transplant, you're also going to be married to that transplant center. Your follow-up is going to have to be in a specialized center. So for some people who are not transplant candidates, that's where the ventricular assist devices come in. Still a major surgery, but much more readily available and without the wait times. So for somebody who's too sick to wait the 6 to 12 months for a transplant, maybe they're a candidate for a ventricular assist device, which brings about different benefits, different costs, but it is too an option. But I think for those who are candidates for either of those surgeries, they can do very, very well. Not everybody is a candidate, but again, I think for those that are, there is a lot of benefit. There is a lot of quality of life that can be brought back. Again, just, success story after success story, of people who have kind of gone on to live full, meaningful lives.
Right. Yeah, and I think what you did for me when I rotated through here, I won't say how long ago it was because you looked there. Yeah. I said, don't say how long ago it was. But, and that's because I saw what that process was then. I was amazed by it and saw those stories. And now, just because I could see many of those same patients, new patients, coming out doing half marathons, 5Ks, and really just living life the way that it should. But transplant, again, and you said it at the end, not everyone's a candidate. But I know that how we make those decisions about transplant sometimes are couched, and I know that's not the case here. I've actually had the chance to sit in on those boards and to see how objective and very perfunctory it is. But in many cases, social determinants kind of impact who gets what, sometimes because, there's not a large donor pool. That's a place of education. But when you look at underserved communities, communities of color, those that don't have access, is that an issue in the heart failure space? And if so, to what degree?
I think it's a huge issue, but at different ends of the spectrum. So where we are, by the time they get the access, by the time they get referred to us, the patients are seen by a cardiologist who does the medical side of the management, a surgeon who does the surgical side, but they're also seen by a social worker, financial counselor, nurse practitioners. So there's the full evaluation of candidacy. But I think the problem is it's a pyramid. Those who kind of make it to the top of the pyramid, they've got the access, but a lot of times people can't get into the base of the pyramid. They don't have the access. There's only 140 transplant centers throughout the country, which means for some people who live in very, very large states, they can't get to the transplant centers, or they may not, they may not have the means to do the travel. They may not have the money to pay for the medications. And, one of the things we do have to explain is that, because these are very specialized procedures, and it's not just the procedures, the afterwards, even if we as a transplant center waived all of our fees, all the doctor's fees, all the hospitalization fees, all the surgical fees, for the initial surgery, they still need to pay for the next 15 or 20 years of medications for the rest of their lives. And so the problem is one of access and it's one of equity, right? Not everybody can afford those medications.
Right.
So I think the problem is actually a societal one where people don't have the access to the care, right? I think once they get into the system, I'd like to think that, the access is more, it's more well-rounded and it's less biased. But those social determinants of care still factor in. Medicaid isn't accepted by many transplant centers, not because Medicaid pays poorly, but because with Medicaid, you have the other issues. They don't have transportation. They don't have reliable access to medication. And they don't necessarily have the social support to take them to and from the hospital, or if that patient gets sick, for somebody to recognize that they're sick and bring them to the emergency room. So I think it's a fundamental problem, but at a much more basic level, in terms of that access of care.
My goodness. And you did a great job of articulating the layers, because I see it on the one side, but you mentioned, hey, look, it's not just we fix you and you're good. This is a 10, 15-year relationship that has to be established, fortified, and sustained for those individuals to have success. Now, do you know of any policy drivers to make it more equitable? And I guess that's the easiest way I can ask that question, because I know that question has layers as well. But I know that sometimes when we can't locally do things with the tools that we have, we allow policy to drive some of those things. Do you know about any of those, or have you been a part of any of those?
No, that's a great question. And speaking outside of the heart realm, for example, transplantation as a whole, because as you know, I'm sitting on the board of directors now for the Organ Procurement and Transplant Network, or the policymaking body for transplantation. But one of the things is, traditionally, for example, in kidneys, we calculated kidney function using a formula that was race-based, so that African Americans had additional their kidney function was overestimated. So we actually just recently took race out of that calculation, so that it could be more equitable, so that wouldn't count against them. Because if your kidney function is calculated higher, then you are less likely to need a transplant. So recognizing that some of those formulas were dated or were completely based in size, those were taken out of the equation. The people who had been listed went back and got retrospective credit for that time where their GFR, their kidney function, was higher than was calculated. So they're making a conscious effort to look at those kind of things. And there's actually a minority action committee that actually looks at these kind of things, and with on the board to kind of bring these things to the attention of the board to say, look, this is an issue, there was an unconscious bias, and we need to relook at it. To the degree that science, sometimes the science is ahead of us, sometimes it lags, but clearly it's something that we're trying to be very conscious of, so that there is more equitable access.
So you've hit all the buzzwords, because you might not know, so I am a bias trainer with the American College of Cardiology, in a sense where we want to highlight where that occurs and look to policy decisions to identify, optimize, and create strategies to where everyone has equity, right? And so I don't know, I'm gonna have to pull you in, because but because we hear about it, we see it, but then we are oftentimes on the general cardiology side don't see what's happening. We just know that, well, my patient can't X or this patient can't Y, but knowing that there are strategies, and the example that you gave with the risk model, right? Framingham, it's great, but it did include people like you and me, and we know now that, well, just look for, if you want to know about atherosclerosis, just get a score, just directly visualize, and what we can see that is there are variations to that. Well, as we round out, I want to, if you had, let's say, 3 takeaways for folks to kind of think about when it comes to heart failure, and this is, I guess, more geared toward patients, what would you tell them, right?
So I think that, it's like in the midst of all this technology, we kind of, you go to a hospital, they order an echo, they order an MRI, they order a heart catheterization. And I think that there's much more simple things. If you have the diagnosis of heart failure, what we tell people is the most sensitive marker is rapid weight gain. So the rule that we use is 3 pounds in a day, 5 pounds in a week. If you're gaining weight that rapidly, it's probably not muscle. If you're losing weight that rapidly, it's probably not diet, but that may be fluid fluctuations. So you see those kind of changes, let your provider know. And I think that one of the other things that we typically do is we tend not to focus, and again, this is for patients who already have the diagnosis of heart failure, we try not to focus on the diuretics. The diuretics are the water pills that eliminate extra fluid. But the way I describe it to patients is, if you think of heart failure as a sink that's overflowing with water, the diuretics sweep the water out of the sink so your shoes don't get wet. But by putting you on the other medications that lower the blood pressure and suppress the neurohormones, the stress hormones that create the disease, you're actually removing the stopper from the sink and letting all that fluid drain out. So as opposed to focusing on scooping water out of the sink, we focus on removing the stopper, letting the blood move forward. So lower blood pressures with the right medications actually helps to heal the heart a little bit better. And then I think the third thing is just, having having the ability to call your provider early and not waiting until the routine appointment in 3 months, because 3 months may be too late.
Right.
If you're gaining fluid rapidly, if you're having symptoms, being able to call that provider earlier rather than later, because an ounce of prevention really is worth a pound of cure. People say, I don't want to sit in an emergency department for a day. I get it, but it's better than sitting in the hospital for a week if you wait too long. So I think that especially with heart failure, getting in early, before the symptoms progress, can save a lot of time and heartache.
Wow. Beautifully articulated. Now, I know I said that was I got to ask 2 more questions. And then I'm going to, because again, I don't get to sit down with you. This is the problem. I'm just going to swing by and say hi. So I got to ask about lifestyle, right? Because you're fit, you exercise, again, you haven't aged a day. I need to know where we're hitting the fountain of youth in here. But what is the value of lifestyle strategies? You mentioned stress hormones, stress reduction, yoga, exercise, diet. I am plant-based. If you didn't, I am. I try to transition most of my patients to a plant-forward diet, sleep hygiene. What are the benefits of lifestyle in heart failure?
So those are huge. And so I think one of the big misinformation pieces that we hear a lot of is that if my heart is sick, I need to rest my heart. And I think it's just the opposite. Mm-hmm. I tell people the heart is a muscle. And like every other muscle, if you don't use it, it's going to get weaker. But you have to be smart in how you exercise it. So I think that I tell people that walking is better than running. 30 minutes of continuous activity a day is generally the goal. And eating well, because what you put in really affects, it's like how your heart, how your body is going to metabolize. So I think structured exercise, focusing more on activity rather than on intensity. Duration is going to be more important. And there's plenty of fad diets out there, but a lot of times fad diets, you lose weight because it stresses your body. Mm-hmm. So, slow and steady wins the race. So better diets that you can sustain, just like activity. It's like the continuous activity, the slow weight loss, the diet that you can live with for the rest of your life, not just these crash diets that last for a week.
Well, good, nice and said. I mean, I got most of my patients doing that. And I could tell you that because I'm plant forward, a lot of my patients will, not vegan yet, but they are moving in that direction. But again, thank you for speaking with us. Now, I know people are going to want to know, well, I have heart failure, and I want to come to a great place with 4 pods that has pulmonary hypertension sections and they want to know. So how can people contact your clinic or get their provider to contact your clinic to engage with this type of a setup and this ideal nature of holistic heart failure care? I'll go ahead and stamp it that if it's not already, because that's certainly what it seems to me.
So, I think for people, for us in particular, it's relatively easy. We're here in San Antonio. We're the only transplant program in San Antonio. So they can look us up, and they can kind of give us a call, and usually we require a referral from the provider so they can send old records. For those who don't live in the San Antonio area, you can actually go online. You can look up the SRTR, the Scientific Registry of Transplant Recipients. So it's SRTR. I think it's .org. But if you actually look it up, then you can actually look up transplant programs by state. So you can look up state of Tennessee, kidney transplant, pancreas transplant, and you can find out where the centers near you really are, and you can find out what their outcomes are, what their volumes are. And again, an informed public is the best public. So you can actually look, and you do have the luxury of choice between centers. You see which centers do more transplants in your particular organ field, which ones have the better outcomes. How do they select? What's the waiting time on the list for them? All of these things factor into it. So SRTR is a good place to go. Again, I think that, if you're going to go look at these kind of websites, make sure that it's not ihaveheartfailure.com, right? It's something that actually vetted by somebody with, that can actually look across the entire spectrum, look beyond just the advertisement from the individual sites as well. They'll tell you what they want you to hear, but be a smart consumer, because again, you're making a lifelong decision. And so sometimes the closest, sometimes the quickest isn't always the best.
Right. Well, thank you again. I appreciate you for taking this time out and discussing this with me. I'm sure folks are going to have more questions, but you have set a beautiful foundation, and I think it's a great way to add to the compendium of information that people can trust when it comes to heart health.
Thanks, Travis.
Yes, sir. Yes, sir. Thanks again. Well, as you all know, this is Dr. Banks with the About That Life podcast, the podcast about life, where today we talk with one of this city's, this country's, this world's experts when it comes to heart failure care. The holistic heart failure care that's delivered here under the leadership of Dr. Kwan is second to none. And as he said, sometimes the quickest, the least expensive, the closest might not be your best bet. So be a good consumer, do your due diligence. But more importantly, he highlighted the importance of connectivity. Staying connected with your doctor, educating yourself, and identifying strategies that you can use to improve your heart health in the setting of heart failure. Nonetheless, as you look forward to the rest of Heart Health Month or the rest of this year, understand that you can improve your health by living intentionally forever. Thank you.
We truly hope you enjoyed today's episode. If you did, share it with a friend, leave a comment, and certainly join us for our next episode of the About That Life podcast.